Health equity is more than knowing the language your patient speaks or the country of their heritage. As practitioners, we need to have knowledge of our patients' cultures, religions, and the societal biases that affect how the healthcare message is received and acted upon. At the end of this course, you will know what health equity is, how it affects our lives, and how we can be a mechanism for change. You will be able to explain the difference between equity and equality, as well as implicit versus explicit bias. Finally, you will understand the concept of cultural humility and will know how to apply culturally and linguistically appropriate practices. In some conversations, and even in some publications, equality and equity are used interchangeably. However, as you can see here, there are real and important differences. All of our members have assigned PCPs and are notified of that assignment during enrollment and onboarding. So all of our members have equality in the ability to have medical care, including an established relationship with their own personal physician. But is that equity? Not really. What if a patient is doing shift work and takes off for that 2 p.m. appointment? They lose that day's wages and maybe the rest of the week. What if they can't pay full price for the care? Does the provider charge based on their patient's ability to pay? What if a specialist only sees Medicaid patients in the afternoon on Wednesdays? Or what if the patient has no transportation or no one to watch their children? What if the patient feels the provider office looks down at them due to their race and accent, the way they dress, or because they identify as a gender that is not their birth gender? Our members often face these situations, and many more barriers to care are due to social factors and existing stigmas in the medical system. So equity in healthcare often means eliminating or at least reducing the social and economic pressures that affect care, as well as ongoing education to providers and their staff so that all have the same opportunity for fair and appropriate care. Let's look at other issues that affect health equity. Bias is a human trait resulting from our need to classify individuals into categories so we can quickly process information. Bias is a strong barrier to equity in life, period, and very much so in healthcare. These are good and bad associations or stereotypes. In other words, they are the ideas about people, places, and settings that influence our thought processes. Implicit bias is unconscious, without thought, and we all have it. We do this by automatically processing a situation. For example, you see a person of color walking toward you on a street and you move your purse to the other side of your body. Another example is stereotyping, such as thinking that all Italians are part of the mob or that all blacks belong to gangs. It's the labeling of any group, be it ethnic minorities, immigrants, the poor, sexual minorities, the elderly, the mentally ill, the disabled, or those unable to read, and the assignment of an attitude to that group which changes how we interact and care for the person. Explicit bias is when a person is fully aware of prejudices and attitudes towards certain groups. Overt racism and racist comments are certainly negative explicit bias. There is explicit bias in healthcare guidelines. For example, for newborns with jaundice, the current guidelines suggest that blacks tolerate a higher bilirubin level, thereby delaying treatment for infants. Another is that blacks have more muscle mass, so their test for kidney function, known as a GFR, is scored on a higher scale than that of non-blacks. A 100-pound black woman might not be listed for a kidney transplant due to a standard setup in 1912 that erroneously shows that her kidneys are functioning better than a 180-pound white male with the same GFR number. The American Academy of Pediatrics and the American Society of Nephrology are currently reviewing these biased practice guidelines and others for needed changes. Cultural humility is much more than cultural competence. Cultural competency is the ability to understand and respect values, attitudes, beliefs, and functions effectively. It is not enough to just know that there are cultural impacts on engagement in medical care. Cultural humility is admitting that one does not know how the impact works and being willing to learn from patients about their experiences while being aware of one's own immersion in culture. A humble approach to all persons is to be person-centered, open to and respectful of the other person's views. This entails self-reflection and personal critique. Cultural humility is demonstrated when a learned medical practitioner can respect and help someone through a health need, even when they see and live in the world differently. I'll share a personal experience. I was working in a step-down unit at the hospital, and on my team was a middle-aged woman from Haiti. She became slightly dizzy and complained of a severe headache. She started to sweat. I took her blood pressure and it was sky high, critical values. She denied having high blood pressure and refused to go downstairs to the ER. "It is my fate and my faith," she stated. I had her sit down since she refused to lie down. I asked her why she wouldn't go downstairs. She explained about her culture's relationship with medicine and sickness and how they would overcome their illnesses with prayer and by drinking various types of tea. She again stated, "It is my fate and my faith." I looked at her and explained that it was fate today. I wasn't supposed to work that unit that day, and we weren't supposed to be paired that day. But by fate, we were together, and my faith in my church and as a nurse told me I was supposed to help her get care that day. She looked back at me and agreed to go downstairs. She was treated in the ER and continued ongoing blood pressure treatment. Cultural humility is the need for active participation. It is listening and not just hearing, respecting and responding without judgment. So how do we do all of this? The foundation for this are the class practices. This is a set of 15 national standards that cover leadership, workforce, communications, language, accountability, and improvement. The first class standards were developed in the year 2000 by the HHS Office of Minority Health. The standards were enhanced in 2010 to include a comprehensive series of guidelines that inform, guide, and facilitate the practice for culturally and linguistically appropriate services. The Community Care Plan Cultural Competency Plan is based on these standards. The 3 goals of our plan are to 1. Ensure that services are provided in a culturally competent manner, including those with limited English proficiency, whether at the community care plan level or at the provider level. We monitor this through complaints and grievances, cross-culture reports, and the member satisfaction survey through questions about whether your doctor knows your culture and speaks your language. 2. Effectively provide services to all people, regardless of their ages, cultures, races, ethnicities, sexual identifications, and religions. Monitoring includes reviewing the demographic profiles of the service areas, the number of providers with languages spoken other than English, and providing customer experience in 3 languages, plus having a language line. And 3, conduct an annual evaluation of the effectiveness of the Cultural Competency Plan, including all results of the monitoring, improvements, opportunities, interventions implemented, and focus for the next year. If you don't study it, you won't find the problems, and you can't fix what you don't know about. So what can we do? It is important to collect data on who our patients are. This means collecting complete demographics beyond name, address, and gender at birth. It means learning about cultural differences, as well as learning how to listen and respond to a patient's needs and questions responsibly and respectfully. We must work within their beliefs and cultures instead of forcing them into a mold of Western medicine's making. With respect to gender identity, transgender, and sexual orientation, there is a need to gather and then use the information to tailor the care to that person. How would you feel if your health plan kept sending pap smear reminders to you after you have transitioned from female to male? It is also important to use appropriate pronouns with the person on the phone and in person, such as he, she, they, them, sie, zir, or the person's name. This allows us to be more inclusive and respectful. When it comes to race, There are some differences in disease prevalence and response to disease that should change the treatment for an individual. For example, Blacks have a higher incidence of high blood pressure and preterm births. Black women have 3 to 4 times higher risk of pregnancy-related death. Native Americans have a much higher prevalence of diabetes, 26.9 per 1,000 versus 6.8 in whites. Hispanics that are diabetic have a higher complication rate of their diabetes with minor upticks in their hemoglobin A1C. These differences are not due to socioeconomic factors such as being poor, living in a rural community, or not having access to fresh fruits and vegetables. There are other race disparities that need work. For example, whites are medicated for pain after surgery 2.5 times more often than blacks, based on the belief that blacks have a higher pain tolerance. There's also the belief that an Asian person must always be medicated because they are stoic and will not admit to suffering. Black men die on average 5.1 years earlier than white men, and black women an average of 4.3 years earlier than white women. Latinos report fair or poor health at higher rates than whites. Asian Americans report the best overall health, but delving into subgroups finds that Vietnamese and Korean Americans have the highest rates of cervical cancer, and Vietnamese men die from liver cancer 7 times more frequently than non-Hispanic white men. Remember, if you talk to a person in a language they understand, it goes to their head. But if you talk to a person in their language, it goes to their heart. And the same goes for acknowledging and respecting a belief, a culture, and a heritage.